Hello, everybody. This is Kumar Madasari from Rush Medical Center in Chicago, one of the vascular interventional radiologists. Today in this talk, we're going to talk briefly about aortoiliac interventions with a hybrid approach, specifically in patients with common femoral artery disease. As you can see here, this is my disclosure slide. Moving on, what are the objectives here? We want to talk about hybrid approaches to peripheral arterial disease patients, anything data-wise, which is not very heavy in this talk, and also more importantly, some case examples and what the approach and reasoning was. So why hybrid? Conventionally in the past, TAS-D type patients and lesions only had surgery as an option, which is well suited at that time. However, over the decades, we've seen an abundance of endovascular procedures which have significantly been improved in terms of technique, technology, and what we believe are outcomes. So hybrid approaches have increased along with that in order to give the patients the best options. What are the benefits? Reduced operative time, reduced hospital stay, and reduced mortality and morbidity, which are very important in our current healthcare system and for the patients as well. What are the issues with it? A high level of both endovascular and surgical techniques and approaches are not always available everywhere, so that's one caveat. There's always some politics, which we're not getting into, which shouldn't be the main issue anyway. And also timing of doing these procedures, if they're going to be done in conjunction or at separate times, and a lot of that plays together. In terms of best practices for these patients, what works best is that there's open dialogue between the operators involved, whether that be interventionalists and surgeons, physicians, caretakers, whoever else are involved. There needs to be open communication in the patient as well and their family. And it's also very important to have good angiographic imaging for these cases, whether that be with cross-sectional imaging, which some of us don't rely on a lot, but it does help you in these cases when you can't have great femoral artery access to do the angio. Some people do like to use radial or brachial access to get the angios if needed, but cross-sectional in some of these cases can help you, but having good imaging to make a plan is very critical for these patients. Endovascular management of iliac disease alone is sufficient if there's good outflow, and that's great for a lot of patients with claudication after they've optimized medical therapy. However, combined surgical approach, if there's also common femoral artery disease, is kind of the most common scenario in most of these. Now, there are radial approaches to treating a lot of the disease involved down the pelvis nowadays, but a lot of times if you don't have common femoral arteries that are good, you still want to consider a surgical approach for those unless there's a reason not to. And also, you need aortoiliac revascularization when you're anticipating a fem-fem bypass for these patients as well. So any data-wise, again, this is probably the only slide involved in this. They looked at it in 2014 by Maurizio, and they looked at patency rates of hybrid treatment in a number of patients, and they were pretty respectable for up to 3 years. There was no real difference between the hybrid and endovascular approaches in terms of patencies as well. So here's an example here of a 63-year-old patient, left greater than right, bilateral critical limb ischemia with rest pain, no wounds. Both common femoral arteries are diseased in this patient, had been able to pick up that just by physical exam with very poor palpability, and workup was performed with cross-sectional imaging, which are not included in here, but the patient not only has common femoral artery disease, but also right iliac disease with significant stenosis. As you see here with accessing the patient's right common femoral artery, you can see how poor the runoff is just from the small forefront sheath. You can see the collateralization already, and just trying to get a wire up there was achievable. However, there's no runoff in the infrainguinal space. There's a lot of collateralization, which is not included in this picture. It is included in the picture on the left here, as you can see, extensive collateralization. Looking at the bilateral infrainguinal space, there's distal reconstitution of the right popliteal artery, and on the left, you can see there's faint opacification with collateralization as well. So this patient's plan was, let's approach the right iliac system and try to treat that so that the patient can get a right-sided endarterectomy patch as well to start with their claudication symptoms first. So once we got across, got a omniflush catheter into the aorta, you can see the run from the aorta, and there's disease in the common iliac artery after angioplasty still. You can see the picture on the right has a different obliquity, kind of separating the internal and external iliac arteries. The internal is providing quite a bit of the collateralization, as you can see in the bottom part of the image. In this patient, decision was made. We put a stent in the common iliac artery. There's a lot of questions about self-expanding versus balloon expandable, covered versus bare metal, and in general, for patients with heavy disease, I like to go with covered balloon expandable stents, just personal choice, as long as I'm not jailing off the internal. At that point, into the external, I'll use self-expanding bare metal stents. Operator preference. I know we have some data with the COBAS trial and everything else that everybody tries to use their judgments on. This patient eventually underwent a fem-fem after fixing the femoral artery as well. Another case, 75-year-old bilateral rest pain, has also right-sided common femoral artery disease. Here's the angiograms, static images. You can see there's bilateral common iliac artery disease, a little bit of disease in the distal abdominal aorta, however, not pertinent here. Internal on the left is seen on the left image, and internal on the right can be seen on the right image. So in this situation, we get bilateral access. Most of the time, 018 wire with a angle catheter is sufficient. Sometimes escalate up sizes. When there's heavy disease, I try to limit the size profile until I'm ready to treat it. So in this situation, got up to both iliac arteries into the aorta, got marking catheters as well as bilateral sheaths, and then did kissing, covered balloon expandable stents, as you can see here. And after balloon expandable stenting of the common iliac arteries, you can see there's flow down the iliac arteries, down the external iliac arteries, and the patient eventually underwent right common femoral artery endarterectomy and patch for their symptoms and has been since improved. I think this is the final case in this series. A 78-year-old has a history of comorbidities that we expect with a lot of our patients: CABG, former smoker, bilateral thigh claudication, has tried optimal medical therapy. Exercise has been attempted, however, it's very hard, as everybody knows, to get this to be standardized. Intermittent bilateral toe pain as well, no wounds at the time. Patient was offered an aortobiofem elsewhere, however, patient did not want any abdominal surgery, has had surgeries in the past, and just kind of has felt would like any other option first. So after our team saw us at our hospital, we decided together with vascular surgery that let's do aortoiliac intervention and then possible fem-fem if that's successful, which we assumed we would be. As you can see here on the left complementary artery access, similar to many cases you'll see by others, there's just not great flow. There's a lot of collateralization. You can see the arteries well calcified. Interestingly enough, this patient has had stenting in the past elsewhere, however, they had occluded as well. Extensive collateralization, as you see on the pictures on the left and the right. It almost looks like what you see most is the uterine arteries extensively corkscrewed, but more or less just kind of exemplify how bad the collateralization is. And decided to do aortogram from the arm, and you can see arm access, so you see the aorta, distal aorta is okay, but no iliac artery pacification. From above, just tried to create a path by ballooning in the left side to see if anything opened up. Nothing did. So then we proceeded with bilateral cut downs with the assistance of our awesome vascular surgery colleagues, and just using micropuncture and 018 wires, and then small support sheets and catheters, we're able to get up to the aorta, get a marking catheter, and get our access. And then just using the sheath dilator sometimes is helpful to create a channel. And this was not a live video, just a static image, but you can see the dilator through the sheath. And some people use a balloon method, like we do for many times, but the dilator itself provides a rail sometimes to advance the sheath. So that's what we did in this regard. You have to be careful. You don't want to shift plaque and other things once you're in the aorta. Subsequent to that, put a stent from that left side all the way down, because we figured this will be almost like a aorta uni on the left. So put a stent, and as you can see, there's flow now down the common on the left to the external iliac. What we did notice in this situation was that the stent at the top, the VBX, had plaque shift to the IMA because it was very close, and we lost some perfusion to the IMA, which was a primary source of collateralization. Therefore, we used a tip deflecting sheath and got into the IMA and decided to balloon that and stent that in order to preserve flow, because we don't want to compromise that in case something had happened to our revascularization. Patient underwent a fem-fem bypass after that aorta and left-sided revascularization. In summary, hybrid approach to peripheral arterial disease interventions have grown significantly over the years for patients that can benefit from both endovascular and surgical interventions, and it takes a collaborative effort in many places, and should be the case and should be an active discussion for every patient to see that we're giving them the best chance to live a long quality of life. Thank you very much.